This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome back to another episode of the Dysrupt Healthcare Podcast. I am with somebody that, I love when you surround yourself with smarter people. Not only is she a real healthcare provider, she's kind of a benefits nerd. And so it's always fun to geek out with Miss Dr. Dickerson, that we call her affectionately a lot of different names, but she is the mastermind behind Green Imaging. Dr. Dickerson, if you could make an introduction to yourself and your great company, let's start there.
Okay, great. Happy to be here, Lester. And I'm Cristin Dickerson. I'm a radiologist. I still practice radiology and founder and CEO of Green Imaging. I founded it 15 years ago to solve a problem in my community, which was there wasn't affordable imaging. And that turned out to be a national problem. And I, like he said, I'm, benefits nerd. I had run a self-funded healthcare plan when I was president of a big multi-specialty group in the Texas Medical Center. And we were direct contracting 20 years ago. So I knew that this could work in the self-funded space. And we started doing that 15 years ago, and we have to look back. It's a great model.
Awesome. Dr. Dickerson, so, maybe let's start at the macro perspective of a statement that I heard that I talked to you about when we were prepping for this of like, hey, imaging, is it that big of a deal, right? So let's zone in, because what I love about this conversation is do something, right? Don't just keep taking the same old crap. This is such a absolute laser focused thing. So let's start with the global. Give us some global stats around imaging: cost, percentage of the overall plan, number of members that usually use it, anything that you can think of there.
Yeah, Lester, it is a really big deal, and it's becoming a worse deal. Imaging cost is rising much faster than healthcare inflation in general, which is rising too fast. And that is in part because of private equity acquisitions of imaging centers and radiology groups. They're aggregating, they're all billing out into the best old contract. And so those costs are rising. Also, hospitals are not able to collect from patients. That patient responsibility has risen because of high deductibles. And so they're collecting 20 cents on the dollar from the patient. They're trying to get to the plan. So they're charging more and more for these exams. So that's kind of the macro setting. When you look in the claims data at imaging, Aetna is going to tell you it's 5% of your spend, which is absolutely wrong. So I had a Fortune 500 company that had a CMO, and he gets Aetna on the phone with his rep, and he says, she's saying it's 11%. We're now seeing 12 and even 13 sometimes. But this was a couple of years ago. She's saying 11%. You're saying 5%. What's the difference? And the guy goes, I don't know. And so I go, okay, where are the professional fees? And he goes, over with the physician services. And I said, where are the radio tracers, the contrast, all those really expensive drugs that get administered for these cardiac tests? Over with the HCPCS code. So when we rebundle all those codes that really apply to imaging and pull in the hospital procedure, the hospital revenue codes that hospitals sometimes use to they escape the adjudication, and they sometimes use those instead of CPT codes. When we pull all those together, it's 11, 12, sometimes 13% of the spend now. That's significant. And what you come back to is, unfortunately, nobody except my family has a favorite radiologist. It is an easy lift. It's not like changing somebody's pediatrician or gynecologist. At Benefits Pro last year, I was on a panel, and I asked a bunch of great advisors, what's the first thing you do, thinking it was going to be direct primary care? And 2 of the 3 said Green Imaging, actually, because it's the easiest lift.
Interesting. Wow. So if I do some simple math and I say, hey, the last Mercer, Kaiser Family Foundation, whatever, per employee per year cost is $15,000 a year. And I take, your 11% on that, right? Just again, ballpark, back of the napkin math. I'm looking at $1,600 a year on there on a per individual basis. So we are talking a sizable number when we think about a chunk, a thing to focus on. So let's start with your most favorite programs out there. What are they doing? So what were they doing before? Because I want to tell the audience, hey, this is what people are doing now. When they take this idea, this is what they're doing. And these are the levers of success. I'd like to dive into that conversation.
Well, I think our school districts do it best. And, in some reason, you're looking at that 1,600, a lot of that in the working age world is women because they've got gynecologic issues and breast issues in that age range. And so a lot of women are high utilizers of imaging in those years. Once you hit 55, the men start peaking and, it starts changing there. You get cardiovascular and musculoskeletal issues. But really in the younger age group, it's largely women. And, one of the things that I think is super important is, okay, so there is 1,600 that's happening. There's more than that that's not happening because people can't afford it. There's that access issue. And, I thought it was really easy. I heard Elizabeth Mitchell say for the purchasers business group that her employers are so worried about the time. They think they're spending as much money on the time lost from work with people trying to navigate care as they are for the healthcare spend itself. And so that access to care is really, really critical. And I think when employers focus on getting people access, making sure they're getting their mammograms, they can afford to do this. This is the really important, and I'll have a visual for you in a little bit, but they can several times over save on the exam and still make sure people are getting at zero out of pocket the care they need. And they're still saving a ton of money. So it's really, I think, about emphasizing the access, making sure people are aware they have this benefit. I mean, the school district in your area that we visited recently with the insurance committee was talking about putting up signs in the bathroom to remind people that they had the green imaging, benefit. So, and
let's play on that. So I'm a school district employee, or I'm any employee, but regardless, it doesn't necessarily mean a client has to rip out the logo that they're used to. This literally could be alongside a normal health plan and they have green imaging. Now what? Walk me through the rest of that.
Yeah, there has to be a financial incentive to use this because people don't know what the time savings are up front. They don't realize how much easier it's going to be. There has to be a financial incentive to use this. We even have employers that will pay not only zero out of pocket, but $400 if you get an MRI with green imaging. And so there are some real financial incentives there. And as the costs have risen, people don't always know what a big deal is. And they say, oh, I'll just use my regular benefits. They then come back once they get a price quote for what their out of pocket is going to be. So it's really that they have to understand that it's zero out of pocket if you come to green imaging. You're going to be subject to your copay and deductible if you go elsewhere. So, that's the first step. And I do believe in choice. I think people should have a choice. Time value of money matters. What could be emergent care really, but we do have employers that green imaging is the only option now if they need non-emergent imaging. And so, interesting that school district has crept from the first year we had, it was 2020, despite COVID, we had about 1.5 million in savings for them. The next year it was 2.5 million. The next year it was 3.7. So once people use us, they come back and that word of mouth gets out there and, it keeps expanding. That part of it's really interesting. And so now with them, even though they have a choice, about 80% of them are using us.
So I think about this and as somebody who, obviously works with you and designs plans around this kind of stuff, it's almost one of those things that's it's too good to be true, right? Like honestly, at the end of the day, wait a second, I am able to give this benefit to my employee, their family member. I can charge them zero. All they really got to do is call this number versus call this number. So walk me through now. Let's spin that conversation. You're not sending them to Tijuana. You're not doing something where these are radiologists and locations in their markets. Sometimes, the hospital's right there and this location's right there. Talk to me about the flip side of it. Who are these people? And I guess the obvious question, if I'm a skeptical CFO who's listening to this, is like, why the hell would that person take less money enough where it makes it financially feasible for me to waive all costs for my members? Talk to me about that side of the house.
Yeah, that side of the house, as a radiologist, I've owned 5 imaging centers in my career. I know the pain points of the imaging centers. So what I want to do is become their best client. And so we give them clean orders that are already radiologist protocol. There's no author verification on that end. You've heard prior auths. We none of that they have to do. There's no bad debt. There's no patient collection. We pay them a fair price that's usually, in the range or slightly higher than they're going to get in network. And we're still saving the employer a ton of money because we're getting them out of unfriendly hospitals. We're more and more able to work with hospitals. We have a good value prop for hospitals as well, especially the ones whose radiologists won't give them cash rates. We can become the cash solution for hospitals. And so it's really about making it a flywheel. It's fantastic for the employer. It's fantastic for the employee. It's fantastic for the imaging center. And then my radiologists who are reading a large percentage of the studies have a great life. It's, and they're practicing population health medicine, which you don't get to do when you're on a time clock reading for an ER. And we're actually talking about the mild compression fractures and recommending a DEXA. We're actually talking about the coronary artery calcium and recommending a calcium score. We're getting to practice kind of in a DPC-like model, kind of direct radiology care. And it's really a fantastic way of practice.
And I'm assuming, I don't know the difference in classifications and all of this stuff, but I'm assuming, again, you're picking team members that are as skilled, if not more skilled than the folks at the other places. They're still going to the best of the best. Is there an argument at all about that machine that you're sending me to is not as good as that machine? Talk to me about the machine itself, because that's honestly something I've heard differences in opinion. But from somebody who knows this, what's the difference in the machine from here to here?
Right. The machines are going to be the same. I mean, really and truly. And the technician matters. And that is why we have a really unique way to assure quality. And that's that our radiologists are looking at those images. We're looking at how the tech positioned the patient. We're looking at the protocol that was followed. And we are, making sure the machine is operating properly. And we're making sure the right radiologist reads it. We've only had to repeat 15 exams. We warranty our studies. We've repeated 15 exams in 15 years for quality. And where we don't read the study, our radiologists can do peer review. We have peer review access to images and reports, and we can do the same thing.
Wow. 15 and 15 years. That's remarkable. So I'm thinking about myself. I just had my triceps come out of my elbow. It was emergent. I went to the hospital. The hospital did an x-ray because it was 5 a.m. They did not do an MRI. So I leave. I need to go get an MRI because I know that there's going to be. Now, my health plan wanted me to get a pre-authorization. I was like, yeah, right. My elbow's like hanging off of my arm here. I'm just going to go. I'll pay cash. I'll deal with this. And this was the interesting part because I am a healthcare nerd. I was like, I'm going to call and price shop this just myself. And so I call and I say, I have XYZ insurance, but I am on a high deductible plan. I need to get an MRI of my elbow. This is what happens. Can you tell me what the price is going to be? She was very hesitant in telling me because she's like, well, it depends. I was like, just give me a ballpark again, underneath the relationship with this big carrier that has big discounts and has lots of buying power. And she tells me $3,000. It was like $3,100. I call back 1 hour later, disguised my voice as a different dude. And I was like, I don't have any insurance. I'm going to pay you cash. $650. This is what we're talking about in the spread when somebody works with your organization. Are we really talking about that type of spread on a what seems to be a fairly consistent service of an MRI of an elbow?
We really are, Lester. You've seen the claims data, and it's mind-boggling. It can be a 10 times variable from what the green imaging price would be in an area to what an employer is paying in the claims data once we rebundle those costs.
And Doc, could it be literally with the same imaging center because their relationship with that big carrier says that they're going to get paid X and they don't have no idea how much it's actually going to be charged for. They just know how much they're going to get paid. And like it's the same dude or dudette, same location, same everything, but you have a deal. Could it really be that difference of a disparity?
It really can be. And it depends on how they look at those things too, because they're not going to collect all of that money at the $3,000, from the average person. And so, we can go in there and negotiate based on what they're actually collecting. The other unique thing is because of our, we're radiologists, we can actually do lease arrangements where the patients remain our patients. They're not the hospital's patients. And that gets around a lot of the red tape that they would have, taking a lower cost.
So I want to dig into this because you and I have a similar passion in this conversation of direct contracting. So I think about what you just said in that scenario, and a lot of people don't understand what we might call a deductible on the insurance side is really an accounts receivable on the provider side of the house, right? And it's a really interesting thing. So I think about this. Let's just pretend I'll be the bad guy. I am the insurance company. You are the radiologist, and we've got the employer over here, right? And you know what? I'm going to kick the insurance company out, and I'm going to say I'm the patient. I'm the patient, the employer, you're the provider. And we're going to talk about this word deductible. I can't afford it. Right? The employee, we've all seen the stats of how many people delay care and not having care, and the average person has $400 in the bank, and an average deductible is now approaching over $2,000. The math ain't mathing. Right. The employer would love to give a better benefit to their employees. They would also love to save money if they could. And the cherry on top is the productivity gain that you talked about of how much easier it is to just go do the thing and not have to worry about that. And then you as the radiologist and the center that is being run, you don't want to collect it. So the conversation of logically, if the three people in that value chain don't want to do it, then why the hell are we even doing it? Talk to me about, as you look at your P&L when you were running the facility, how much is it costing people to collect? What's the math around the waiving of the out-of-pocket? What value is that really getting in return back to that facility?
Anywhere between 20 and 30% of revenue goes to collections and bad debt. And so, when the Affordable Care Act came around, green imaging was, a new entity. And I thought, okay, let's give this a try. And we went in network. Blue Cross Blue Shield wouldn't honor the lease arrangements we have, but Cigna, we went into network with. It was more of the same. I had PTSD from my years of trying to collect insurance. And so, we let about $1 million in revenue go in 2017 and got back out of the traditional networks. And what I would say, in Texas, we're lucky. We have House Bill 2002, where if you're in a plan that's overseen by the Texas Department of Insurance and you pay cash for an exam, you can actually, the insurance company has to take that against your deductible if it's less than the average cost in your network, which, it can very easily be when you pay. So that, that to me is where we should be going with this, is that, yes, that is really an incentive. But the problem there too is that you got to be able to afford the exam. Right. And too many people can't. And so I think it's not just about, about the employer still saving money if the patient has the exam. It's also about making sure that patient gets the exam so that all the downstream effects of delayed care don't happen to that employer and employee.
I'm going to celebrate 24 years in this business this year. I know I don't look it, but I do. 24 years. The first 15, what you just said went over my head. I don't think most employers, and I know most advisors, don't think about the downstream. Don't think about what an ounce of prevention is more than, whatever the analogy is about, like, I don't know, let's put out the fire before it becomes the forest fire, essentially, in old redneck talk, Lester here. Let's put that fire out. And it's so hard to think that it truly is a win-win. Like, you're not like this witchcraft, like voodoo doctor. Like, this is math. This is like arithmetic. You don't charge this person. This person's more likely to do the things that they're supposed to do. They stay healthier. Good. They pay less money over here than you would have paid if they got it over there. Also good. You just gave them a better benefit. That's a recruitment retention conversation. Fan-frickin-tastic. I save money as the plan. Also good. Good. What's the bad? Like, if you had to say, hey, you know what? You and I are out for a glass of wine, and you're like, really, the thing that if I could wave a magic wand and I would fix or so, like, what's the bad? What could be the potential bad?
I think the potential bad is referring physicians, really kind of telling patients that they really shouldn't use screen imaging because it's going to be hard for them to get the images, and it may not be the same image quality. Those are going to be the patients who, really are reluctant to use those. The other piece is that sometimes people are going to have to drive farther. They're going to have, and I can't tell you how many times, if people really understood the relationship between wages and what employers are spending on healthcare. I mean, literally, we have had patients when we have said, not only will, if you stay closer, you may have several $1,000s, but your employer will pay several $1,000s more. People don't care. They don't get the relationship between healthcare costs and wages. And I think James Frank, who is a state representative here in Texas, when he made these changes to his health plan, he told his employees, this money, anything we say is not going in my pocket. It's going in your pocket. And I think that is really an attitude that helps people accept the change that's necessary to change healthcare.
What you just said literally puts the hair on my arm around the, I don't know, do we call it empathy? Right. Do we call it the disconnection between the boardroom and everybody else? And guilty when I was rolling up in my nice, Tom's Jane custom suit, working for a big ivory tower consulting firm. And it was easy to say, hey, if we increase the deductible by X, we get it down by Y. It would have only been 7% of the people, blah, 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 blah. And then now knowing that, wait a second, dip. I grew up in a household whose family had to file bankruptcy because of medical expenses, and you forget what the hell you're actually saying when you say just increase the deductible. That's not that big of a deal. We've lost all connection to the reality of the Joey Lunch Bucket who is doing and is the lifeblood of the organization, doesn't and can't afford it today. sitting on the ground, maybe cutting out coupons for lima beans on Sundays. But then again, we sit in the corner office and they're like, yeah, we'll just leave this kind of money on the table because it might be more confusing. You know what's more confusing? Figuring out where the hell you're going to come up with an extra $1,000 when you didn't have it yesterday.
Right.
And it's such a big deal. So like if you sitting there, you have industries left to right, up to down, you've ran it. If you're sitting in front of a CFO, a CEO, an HR person, what's your pitch around that? Like, what's this conversation? Like, what do you normally say? Because I know what I say, and sometimes it hits and sometimes it doesn't. But you said the thing about choice. So I'm wondering how you think about that conversation when an employer says, hey, is this going to be confusing? What's your response back?
My response back to that is really, I spent the first 14 years of being at Green Imaging emphasizing the cost difference. Once I was on a panel at Houston Business Coalition on Health with Andrea Cockrell, who runs the city of Plano in Texas as health planner. And what she said is, we brought Green Imaging in to solve a problem we knew we had, which was cost. And she said, what we ended up solving was a problem we didn't know we had, which was access. And that access was not just people trying to find some of these exams, new FibroScan, these coronary artery exams. It was people weren't getting care because they couldn't afford it. And that, to me, that was a paradigm shift for me. And I really feel like, I knew that when I started this, I really thought transparency was going to even the playing field, and we just had to be better on customer service. Now I realize we have to be better, not only on customer service, but on access. And really, removing that 8 hours a week that employees are spending trying to navigate care for themselves or a family member. Getting those things off the table for our employers, in addition to saving their money, that's the formula.
God, I love it so much. So let's talk about a real life scenario, because we worked on one together that had some amazing impact. So if you wouldn't mind sharing that while I'll tell the story. So there was a group that is in the staffing industry in offices all over the country. And, again, health plans going up. And I'm going to come back to this, but I'm going to drop it right now. This is an industry that has, roughly a 12 to 15% margin business. The bulk of their employees are making, $75,000 to $100,000. So not lowest on the wage earners, but not the highest on the wage earners. And so, Dr. Dickerson, walk me through what it is that we're looking at and some of your observations.
Well, I hope I'm sharing, because I think,
yes, ma'am, I can see it.
Excellent. Well, this is what we do when we have a potential new client. If we can get their claims data, even if we can't, we have reams of claims data. We can show them something similar. But this is where we go in and we pull the facility fees, the professional fees, the HCPCS codes that relate to imaging, and we show them what the savings can be. And on their CT scans, their average cost of an exam in their network was $4,700. Green Imaging's average in their area, $485. A DEXA.
Oh, wait. Time out. Somebody looks at that and says bullshit automatically. Like, somebody looks at that and says bullshit. So we are talking, all in to all in. We're talking, same exams. We're talking, because you had the claims data here, so this isn't like you guessing. This isn't fabrication. This is literally the same exact people, the same exact locations, the same exact exams. And we're talking, again, not great at math, but that's a tenth of the cost, a tenth.
And I'm going to throw in Al Lewis here, because Validation Institute has validated our means of doing this. So it's not just us saying this. There is validation behind this. And the really crazy one is the next one, the DEXA scan. Look at that one. I mean, $850 for a DEXA scan.
And for anybody who's as ignorant as me, give me what that means in real English. What's the next exam?
Women, her normal risk should be getting those 50 and above. Men who are at increased risk should be getting those.
Okay. And we're talking the average right now of 850 versus 115.
You got it.
So again, not great at math. I go down the right-hand side. I look at this and says, we are literally on average talking about an 85% savings.
Correct.
While also giving the member a free service.
Correct. Okay, this is apples to apples.
So we might need to take a little bit off of that, but it's an employee paid for it right now.
It's an 8 times savings instead of a 9 times savings.
Right. And so in this client, so we add these up. So these are 3,800 transactions. What would be your best guess of how many members, how many belly buttons is that? If you just threw a swag, is there some sort of benchmark?
I don't remember on this one, Lester, to be frank.
How many employees? So they have 2,500 employees, but just wondering hey, how many people would have actually, because what I think I'm trying to come up with is little things mean a lot, right? That's a big savings number. And we might be talking about, 10% of the population, 20% of the population. That's kind of where I'm trying to go with.
Yeah. 40% of people get imaging in a year. Okay. And then, we'll when we start, we'll assume 10% of those will use us the first year, unless they're very, and again, there is a socioeconomic factor here.
Right.
A white collar group, they will use us, especially the ones who really understand the value that's added if they get some education on it. But when you've got school teachers, school bus drivers, cafeteria workers who are not going to be able to get care unless they use us, that is a highly incentivized group. And they're going to use at maybe 50% of that 40% the first year.
So again, let's go with some simple math. Again, and I'm bad at math, so I'm going to literally use my calculator here, and I am going to say there is a $2.7 million savings to this client who makes a 10%. Let's just pretend it's 10% margin because I can do that math. So I think about this and I'm like, okay, if I'm the CEO of this company or the CFO, how much staffing revenue at a 10% margin do I need to acquire on a sales side in order to generate literally $2.7 million? I mean, we're talking, $20 million worth of business.
And here's the icing on the cake. Look at how many of those would have met their deductible with just one expensive imaging exam. And then the plan is picking up everything else all year.
So in case somebody didn't know how to read that you're looking at the cost and saying, hey, if there was a deductible of X, look how many of them on an average per cost basis would have already, surpassed a deductible.
Right.
Literally most of them.
Right.
Wow. And again, let's go back to our highest cost of every employer is our talent, right? And so even if it's not hitting a deductible and it would have been all quote unquote employee costs, being able to sit down with a potential recruit and saying, hey, just so you know, our benefits plan includes this white glove service that you're getting images for absolutely nothing if you work with our advocate-based, company. Like it either way, hard cost, soft cost, left cost, right cost, blue cost, pink, blah, it works all the way around.
Absolutely.
Wow.
And it's really, if you look at what the larger employers are doing in this country, this is the theme for this year is direct contracting. They're leaving the traditional plan in place and direct contracting around it. National Alliance, Purchasers Business Group, that's what they're, trying to get out there and push for this year. And I think, I think we're starting to see some, I'm seeing the traditional plans start talk to us about, if we have a client who might want to use you, how do we work together? And that never heard that in 15 years until this year.
So the reality of this is, if a client, if we think about the crawl, walk, run, conversation, the client can include this in an embedded program, that we're doing with an unbundled situation. The client could have the shiniest of logos on there and offer you alongside of that, and they could still pay for it. The employees could still do all they're doing, and everybody wins. So there's really no reason a client shouldn't at least look at this.
Totally agree.
And you would have a selfish reason to agree, but like I'm like literally as the host of this podcast, I'm trying to think to myself, like, everybody does them, right? Imaging is something that's super common outside of drugs and maybe primary care physician visits. Like, I gotta think it's up there in the top 5 of a utilization, standpoint. It's got a surprisingly high unit cost basis cost that I think a lot of people probably have never seen. Like, I don't know, your average CT is billing $5,000 almost. Like, I don't average person.
I can sell, Lester, is because I believe so strongly in this. I'm not a salesperson. I'm a doctor. I can go out and sell this because of those numbers, because it makes no sense not to do.
And it's good for everybody involved. I mean, that's the thing about this. So, like, if we have insurance advisors that are listening to this, like, this makes your heart feel good. Like, you get out of a meeting looking at that, like, I done good today. Like, I can put my head down on a pillow and be like really proud of the thing I brought to the world today. If I'm an employer, I know that I've given this to my number one assets, right? And we say that in the boardroom that, we care about our employees. And then next thing you know, your benefits plan has a $6,500 deductible HSA and your average person's making $82,000 a year. Right? Like math don't math.
Right. And if I'm having a bad day, I go read our Google reviews, and then it restores my faith in the fact that we're doing this.
I love it. So, Dr. Dickerson, if somebody wanted to get an impact assessment, if they wanted to learn more, let me ask you before I go there. True or false? Somebody can add this benefit in the middle of the year.
They should add it in the middle of the year. Then employees see it as a benefit with a capital B, not as a cost containment strategy. And that's super important. And there's less ways around it.
That was an impromptu question. That was not staged. And you answered it way better than I would have even thought about. I'm like literally in my head thinking, wow, you're right. Hey, we just had a red renewal. Everybody did. I mean, this was the worst renewal season in years. We are rolling out various strategies to, make this more tolerable for you. Step 1, step 2, step 3. I mean, like, so anyway, so back to then my original question. If somebody wanted to get a hold of you, you're a great organization, like get an impact assessment, learn what locations are already in their, in their area, how do they go about doing that?
They can hit our website, www.greenimaging.net. If you do .com, you're going to end up in Canada. It's .net.
Got it. Greenimaging.net. And I'm going to give you your parting shot. Your audience is out there. What's the 2026? Like, all right, no BS. Like, I got you. I'm shaking you. What's Dr. Dickerson saying?
I have people ask me, are people just going to go get imaging because they have this free benefit? And I'm going to tell you, they absolutely do not. I give this benefit to my employees, and they don't use imaging any more than they did before they had this benefit. People do not go lie in a cold tube and take off work and get childcare for their kids to go get medical imaging. So don't be afraid of change. And I think take this as a first step. It is a great first step. It's an easy first step, and your employees will appreciate it so much. When I go to employee events, I can people cry and say, I have been waiting 2 years to have this MRI.
Makes my heart so happy to hear. Dr. Dickerson, thank you so much for the time. Thank you. It's funny. I'm a big podcast nerd, and so I was listening to a podcast, I think yesterday morning. They said, most entrepreneurs solve a problem for themselves and then realize that everybody else has done it. And you're such a great inspiration in there. Thank you for leading the charge. Thank you for bringing such a pragmatic, solution to the table. I have used you myself. I can attest to all of it. And I just love the fact that we can literally have a nobody loses situation in healthcare. And in especially benefits advisory, it's normally a I win, you lose, right? In order for the employer to win, they have to pass on costs to the employees or vice versa. And now this is absolutely an area that everybody can sit around the campfire singing Kumbaya. And that is freaking awesome.
Well, thanks, Lester. And thanks for all you do to put the good word out there to employers. We appreciate it.
Awesome. If you guys want to connect, we'll have all the things in the show notes. This is one of those things that I can't emphasize anymore. And I don't care whose voice is hearing me. Everybody needs this. This is something. I don't work for Dr. Dickerson. This is just a damn thing that duh. That's I think the title of this podcast episode is gonna be duh. That's what I'm gonna make it. Duh, this just makes sense. So share it, like it, go on their website, pull some data, fact check us, try to prove us wrong, do something, but do something. Thank you, everybody, for listening to the Dysrupt Healthcare Podcast. Give it a like, give it a share, give it a comment. Let us know other things that you want to talk about. Dr. D, thank you so much for you and everything you do. And we'll see you guys on another episode of the Dysrupt Healthcare Podcast. Take care.